Good morning, all. I am Dr. Vijay from Divisha Arthritis and Medical Center, consultant rheumatologist. Today, I would like to welcome you all for my educational session on about back pain, with more focus on inflammatory back pain. So, let me take you through some slides of how to deal with back pain. It's a very common scenario, back pain. It is, my professor used to say in England that most of my training has been England, and he used to say that if nobody has had back pain in their life, that means they're not normal. So at some stage, everybody has back pain, be it for a few seconds or a few minutes or a few hours or weeks or months or years. The reason we have back pain is because we are two-legged animals and we stand on our feet and the entire load falls on our back. So that's the reason we have back pain. Okay. So what are the causes for the back pain? So if you look at it, you can have a disc. So these are blocks of vertebrae because as I told, we are two-legged animal. Nature or God has designed that way that we are able to bend, flex forward, sideward. So these bones are supported by shock absorbers or discs. And if the discs rupture and they either go forward or backward, then you have something called a slip disc in common word, or disc prolapse in medical term, pressing the nerves or even the spine or the spinal cord. Then you have osteoporosis. What I mean by that is the spine actually collapses. The shape of the spine here collapses, and that causes something called break in the vertebra. The break in the vertebra, sorry, let me just go back a bit. So the break in the vertebra causes this particular vertebral collapse. And if it's acute, then it causes severe pain where the patient is not able to get up or move. And this happens in people whose bones are very weak, or it happens if you fall from the height. So where there's a break in this, it becomes completely fractured. Or you can have muscle strains. These days, it's very common, muscle strains, especially in work from home people. As you know, COVID has changed all our lives. So we sit for a long time. And if you sit beyond 20 minutes in one posture, especially leaning forwards against this computer table, then all these diamond shaped muscles here are called myofascial area. And the myofascial area are very, very, very prone for tension or spasm. And this gets spasmed a lot. And that gets relieved by frequent change of posture and also by what we call as muscle stretching or through physiotherapy. And moving on, there's something called vertebral stress fracture. This happens in people who are basically or bed-bound or immobile, have inflammatory arthritis or inflammation, what we call in Kannada as Vataroga or Hindi as Vatrog or Gatiyaka Rog, where inflammation in the blood weakens these bones. Okay, so that's one of the features. Then you have something called as sciatica, where these nerves get pressed and the leg pain happens. Okay, so then you have something called as spinal stenosis, where the spinal cord actually goes in this hole. If this narrow structure gets tightened more, then the spinal cord gets compressed or the nerves get compressed. And that causes pain when you walk. That's called a spinal claudication, walk or stand. And that is intense pain. Patients often say that when you walk or stand, they get pain. But when you rest, it's better. That is detected, unfortunately, on MRI only. X-ray will not show that. I often tell patients X-ray is good for the bones or the vertebral bones, but the MRI will show the bones, will show the discs, will show the nerves, which is this part, and to some extent will show the muscles also, whether there's any inflammation in the muscles. Then you have something called spinal osteoarthritis. What is this? Basically, the vertebra loses its shape and it starts protruding out. And you have something called osteophytes or beak-like structures which are popping out of vertebra and causes the pressing of the nerves. See, nerves jet out from these edges of the bones. And whenever there is a disc problem or a vertebral problem like these, it presses the nerves which comes from all these areas. And that's when it causes nerve pain. Now, all these problems, friends, causes pain when you stand, walk, or when you sit for a long time. Very common causes of all these back pain. Some may have it for a few times in a year. Some may have it for a long time in a year. So it all depends on how physically active you are. So causes for the low back pain. Sometimes kidney stone often causes back pain because our kidneys are on the back side of the body. This is the buttocks. Just above the buttocks are our kidneys. So if there are kidney stones, patients often complain back pain, but that you will know if it is coming and going. We call it as waxing and waning pain. That is going slowly above, then coming down, going slowly above, then coming down. And it happens during some times of the day, then comes down. Some times of the day it comes and then goes down. It's not something which persists for weeks to months. And it is, if the kidney stone is moving down the vertebra, then it causes a lot of pain to some extent that patients even vomit or they profusely sweat and those kind of things. If you lift weight in a bad posture, like this is a very bad posture, so then you will have severe back spasm or the muscle surrounding this area gets inflamed or strained or stressed. If you fall down, this is commonly seen above 65 years, where the muscle groups in the legs are here. This part of the legs are very weak, not able to support the legs. They fall down and hurt the back. Okay. Then you have degenerative conditions, which I already told you as osteoarthritis, where the shape of the vertebra changes and presses the nerves. And if these days mobiles, people are addicted, even small kids, even my own kids. So sitting and holding the neck in this way or sitting for a long time can spasm out all your muscles around this side. Okay, that is called as myofascial spasm. Poor sitting posture. We often sit from work from home culture. So long sitting, every 20 minutes take breaks. That's what I tell my patients. Don't sit. Sitting is the new smoking. In fact, Harvard has done a research which says that if you sit more than 6 hours a day, you die sooner than people who smoke more than one pack cigarette per day. So sitting is the new smoking. So every 20 minutes later, keep changing posture. That's very, very, very important. Yeah. So aging is, as I told you, a frequent problem for the back pain. We lose basically bone strength, muscle flexibility. So as we see when we are babies, like animals, we crawl, then we learn to stand, then we stand firmly, then we make postures. And as we age, our spine bends again. Then we use aids or support sticks. So life is a journey. It's a curve. We see that. Age is a major factor. That's why I often tell my patients above 65 years of age to build muscle strength through regular physiotherapy and exercises. Physiotherapy teaching once is fine, but you have to do at home regularly. And with aging, our collagen or support structures or ligaments and cartilage tend to wear out. And as with any wear and tear, they lose their shape and structure. That is basically called osteoarthritis. Poor working posture, I've already told you, prolonged sitting for a long time is not something we encourage. So especially leaning down forwards. Basically, your back should be at the backrest. There should be a headrest and a neck rest, and your computer table should be at the eye level. That's very, very important. And you should have something to rest for your wrist as well. We are all getting fat. Why we are getting fat? Because we sit for a long time, we eat a lot, we work from home, we eat a lot, and we exercise less. So our body can only burn so much whatever we need. After that, it dumps everything in the form of fat. And fats, I often tell this to my patients, fat are basically muscle screwdrivers. So they weaken the muscles, they build fat between the muscle fibers, and muscles get weakened out. When muscles get weakened out, it can't bear our weight. When it can't bear our weight, we have pain. So it's one leading to another. But today, what I'm going to talk to you is more of a problem which is easily solvable, and if not diagnosed, can lead to deformities or lifelong problems where you're not able to stand work, you lose education, you basically get dependent. That's what it is. So arthritis is a common problem. It happens all ages. Often people, my own father asked me, do you treat old age patients? I said, no, my youngest patient is as young as 7 years of age. So arthritis affects young kids also. So that's what I'm going to talk to you about. It affects even old people also. Degenerative is age related, wear and tear, which I just spoke to you about. Inflammatory, which is I was going to speak to you about, which is basically pain, stiffness, swelling, worse with rest, better with activity. So with prolonged sitting, pain, swelling, stiffness in any part of the body, which gets better with exercise. Degenerative or age related wear and tear is more of activity related pain, worse with standing and walking, and better with rest. Exactly opposite way of inflammation. So inflammation can affect all ages, degenerative primarily above 65 years of age. But if you're obese or overweight, beyond 80 kgs of weight, and if you're sedentary lifestyle and family history, then you have wear and tear at a younger age. Even from 45 years of age, you have wear and tear. Okay. Next, what are the symptoms of inflammation? So inflammation is early morning stiffness, that is from 2 a.m. in the morning till at least 9 or 10 a.m. Stiffness or pain, swelling, which is with rest, with some degree of warmth and effusion or swelling. Whereas in a damaged joint, you have more of sounds, as we see in knee problems, that is cut, 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 cut kind of sound when you bend the knee, or muscle clicks. That is more with aging or wear and tear, or even overweight. Yeah. In this, not only the spine, not only this part of the body and the hips, you can also have wrist, knee, ankle, toes. So those are called as oligoarthritis. Oligo means less than 2 to 4. Arthritis means what I just told, pain, swelling, and stiffness. If it's lasting more than 45 days, it comes under the category of seronegative spondyloarthritis, which I'm going to talk to you about now. Collectively, we call this umbrella term as SPA. So if it affects the spine only, the central part, we call it as axial spondyloarthritis. If it affects the what we call as peripheral part, that is joints, then we call it as peripheral spondyloarthritis. You must note here that in this picture, it's not symmetrical. That is, two sides of the body are not involved. So right wrist, left knee, right ankle, left big toe. So it's not symmetrical. That is the main difference between rheumatoid and this particular SPA, that is inflammatory spondyloarthritis. In rheumatoid, it generally doesn't affect the spine or the hips. In this disease, it affects the spine and the hips. And in rheumatoid, both sides of the body are affected. In this, only one side at a time. And in rheumatoid, more common in females. This is more common in male disease. Yeah, that's the key difference. So collectively, it's called as spondyloarthritis, out of which ankylosing spondylitis forms the central core, affecting only the spine. But you have other features. Juvenile is what the young kids, which I told you, until the age of 18 years. And you have something called inflammatory bowel disease, which causes bowel inflammation or ulcers in the bowel, causing weight loss, loss of appetite, poor digestion, lack of absorption, frequent mouth ulcers, extreme fatigability. That also causes joint pains affecting the spine and other arthritis also. Then you have reactive arthritis. What is reactive arthritis? Reactive arthritis is basically that which causes inflammation after any gastric infection, such as loose motion, diarrhea, if you eat some outside food, especially chicken, which is properly not cooked, infections like typhoid, salmonella, shigella, enterobacter, those kind of things. Or it causes after any urine infection or sexually transmitted diseases like gonorrhea, chlamydia. So that causes pain and swelling and stiffness in the joint, especially in the lower limbs. Yeah. So that's what basically it is. You can also have uveitis. As you know, in these diseases, eye has a central structure called uvea, which I'll come up to a short while. That causes red, painful eyes, which I'll shortly describe, show the pictures as well. That alone can be a part of ankylosing spondylitis. So patients often present with red eyes, where they have to rush to a doctor to get drops, otherwise it won't get better. About 30% of patients with this have that problem. But happen at beginning or on treatment or off treatment when the disease flares up. Psoriatic arthritis or psoriasis is a condition which affects, I'll come to that later, 5 parts of the body, that is skin, joints, nails, enthesis or heel or Achilles tendon, spine or joints. That also causes back pain. Then undifferentiated, if it doesn't come under any of these category, we categorize this. So symptoms which you have to never to ignore, as I told, is fever or feverish feeling, extreme tiredness, pain in your jaw, pain in the rib cage. So entire this part of the body pain or central part. Low back pain more than 40, lasting for more than 6 weeks. The junction where your spine meets the hip joints at that part. Some patients, about 30% of patients, may have loose motion or bloating or gas formation. And pain which gets worse with prolonged sitting and gets better with hot shower and as the day progresses. Pain which is worsened in the cold weather. Heel pain or back of the ankle pain. Alternating buttock pain or thigh pain. Psoriasis, which is flaky, patchy skin, which intermittently can go red, worse in cold weather and dry weather. Dry skin and dandruff on the hair. And uvea or red, painful eyes. Any of these symptoms can affect at one time or at different times. And often patients have a family history, somebody in the family having it. You may not have anybody in the family, but also have this condition. So this is the back of the heel pain, which often cause patients complain of that. And the posture here, if you see, it's slightly bent with a stoop, and the legs are not fully straight, they're slightly bent. And this is called as ankylosing spondylitis posture. This is fairly early on in the disease. I've already gone through this part. So if it is shown on the X-ray, it is called radiographic. If it is not seen on the X-ray but seen on the MRI, it's shown as non-radiographic. Rest all part I have told you about it. So SAS is something which all of you have to go and look at, especially those of your patients who are joined this and who have what we call as inflammatory back pain. So it's a Spondyloarthritis Research Association of Europe. They bring out guidelines and do cutting edge research on these patients. So they have classified as who do you diagnose basically with this condition. So in patients with more than 3 months of back pain less than 45 years of age, if you have sacroiliitis, that is seen on the inflammation seen in the buttocks on the X-ray or MRI, or if you have some a blood test showing gene defect called HLA-B27, and any of these features such as inflammatory back pain, arthritis, which I just showed, heel pain, uveitis or dactylitis where the whole finger gets inflamed, or psoriasis, which I just showed, or inflammatory bowel disease, which I just showed, good response to painkillers, anybody in the family having it, HLA-B27 or a gene test done in the blood, or elevated inflammatory markers. So if it is seen on the X-ray or the MRI, you need only one of these. If not seen on the X-ray or MRI or gene test is positive, you need two or more of these. Okay. And if those with no back pain, if only peripheral joints, then any of these features, you need at least one or two of these to actually say that you have this particular disease. You see, in this one knee, right knee is swollen in this, there's puffiness, this knee is normal. So this is an acute arthritis which is seen in this condition. So what I'm showing here is basically nearly 30% of 50% of patients in this blue color having eye problem with this condition. So this is again SAS, which is bringing out their information. They collect data from patients. At some stage in their life, 50% of patients have this inflamed eye structure called uvea in this particular problem. So it's not only joints, it affects several other parts of your body. That's what I want to tell you. And it's only a rheumatologist who has a specialist training in this inflammatory disorders is able to identify that this is caused by this particular problem and able to treat you better with this particular problem. Any other doctor other than rheumatologist is able to identify, but they cannot connect that other than joints, any of these structures is caused by this problem. Or early on, I showed you that this is a muscle problem, not inflammation, who can address patients' problem time to time. So it's better to see a rheumatologist wherever you are. We have rheumatologists all over India now. So better to see rheumatologists and get this clarified. This is the uvea which I showed you, patient presenting with red eye, and you see that there's actually inflammatory cells like water collecting in the eyes, and red color eyes is seen, which is severely painful. Patients are not able to see light and extreme pain is there. And it happens again and again and happens in both eyes. Sometimes at this eye, sometimes that eye. This is not conjunctivitis. You cannot give this to others. It's not spreading. This is not a spreading disease. It's a disease within you only. Immune cells in your body, which is supposed to protect you, is attacking you. That's why you have arthritis and several parts of your body like skin, eyes, joints, intestines, several parts of the body getting affected. It's a situation where your blood is war within yourself. Indian soldiers attacking India, something like that. I often tell this to patients. So we do ESR CRP just to check inflammation level. We do complete blood count or CBC to check whether there's any anemic, to check whether how the white cell count or infection fighting counts are there. And we check for liver to make sure that liver is not inflamed or called fatty liver. What I just showed you on X-ray, we see something called sacroiliitis. That is this particular joint, if you focus here. So this is the buttock bone or sacrum bone. This is the hip bone. This is your leg bone joining the hip bone, also called as hip joint. This is very crucial for our patients to move the legs, bend the leg and all that. And in this disease, this is normal, but when you do the MRI, inflammation is shown. I'll just come to the next slide about that. But within 2 years, it actually progresses and you're seeing the white color structure over there. That is inflammation seen on the both sacroiliac joint. So within 2 years without treated, if the CRP is high, basically SIS is telling us that you need to treat these patients earlier. Otherwise, X-ray changes starts happening in the bone. And you also see something called a squaring of vertebra, and you see something called projecting uh, beak-like structures from the spine called syndesmophytes or Romanus lesions or shiny corners in the at the edges of these spine. More common in males between 15 to 45 years is what we see this disease. In advanced stages, you see, compared to this part, you see there's break in this, there's no joining. But if you go to the next slide, all these edges of the bones are joined. We call that as syndesmophytes. That is joining or fusion of vertebra. So forward bending is very difficult. Body becomes like board-like rigidity, where patients walk like robots. This is advanced stage. We really don't want to see that, friends. And syndesmophytes, you see these edges from here, pointing out here, where the arrow is put. That initially spikes out like this, and then it fuses like that. Yeah. What we don't want is, this is the hip joint, which I just showed. This is your leg bone, and this is your hip bone. This junction, this is the bone which makes you stand on your feet, which makes you sit down, which makes you bend your thigh. So in advanced stages, you see something called as osteoarthritis developing here, all this white line, and cyst formation. Okay. This is heading to surgery, what we call as hip replacement. This is life-changing treatment, my friends. We don't want such things to happen in all our patients. And only a rheumatologist is able to prevent this by giving you timely treatment and diagnosing this. This is missed treat disease. Nothing can save this other than a hip surgery. To prevent this, you need to see a rheumatologist in 2 years of your disease and take treatment to modify your disease called disease-modifying anti-rheumatic drug therapy, which comes both in the tablets and the injection form, which I'll come to treatment shortly. You don't want this to happen. This is something none of us should have. Okay. That is the key takeaway from this. Now, you see X-ray is normal in this. This is within 2 years of the disease, but seen on the MRI. So MRI with stir sequence, where you see white color inflammation of the bone. Basically, this is the buttock bone, which you sit on it. This is the hip bones. So this is the MRI showing a cut piece, like the body has been cut in half like this and showing that. And inflammation is seen on the sides of the bone, that is connecting your buttock bone and the hip bone. This is called a sacroiliitis. So it's seen on one side of the body, that's asymmetrical sacroiliitis. And on the X-ray, we don't see this clearly. So that's the importance of MRI to treat early disease. So if we come to the treatment part of it, what are the treatments in terms of ankylosing spondylitis? So lifestyle changes is very important. This is a picture showing cigarettes into the flush and flushing it. Nicotine makes the gene more virulent. It tells the gene, hey gene, go and attack this patient more. So at one stage, we are removing the disease by giving tablets. And if you continue to use nicotine, that powers the disease more. So cigarette smoking in males, and these days even female smoke. So often tell patients not to use cigarettes. Physical therapy, exercises is very important in these patients. So regular exercises is very, very important. Prolonged sitting is not advisable. Every 20 minutes, keep changing posture. Painkillers, you can use it as and when required. I often tell this to patients that patients call it painkillers, but we call it anti-inflammatory therapy. Alternative medicine like yoga or acupuncture is useful, but on its own, it won't work. You need to use our therapies as well. Prescription medicine, which we give, so in form of anti-rheumatic drug therapies. both in the form of injections or tablets, which are very, very safe. I'll come to that in a short while. SAS again, which I told you, this is the world leading authority, which all of you must go to Google and type SAS and go to their website, and a lot of patient education slides are there. You need to read those. Very, very important. So education, exercise, rehabilitation, self-help groups is the cornerstone. You need to do regular exercises. Physiotherapy, you must contact. We have a physio in our center in the Visha in Basveshwanagar, Bangalore. If not local physiotherapy, you contact. Painkillers or anti-inflammatories are needed at various stages of disease. Initially, I do give patients in form of alternate days or once in 3 days. And then later I tell them to use it as and when required. Tablets such as sulfasalazine or SAS or Sazo or Salazar, we start with 500 mg initially and gradually increase to 1000 mg morning one, night one. At least 6 months to 1 year is required. Other treatments such as Folitrax or methotrexate or Oncotrex or Mext or Mexate, all of these are different brand names, are required if you know more of peripheral joints such as knee joints or feet or ankle. It doesn't, Folitrax or methotrexate doesn't work very well for spine. Sulfasalazine works for spine or the hip joints. The problem with these Folitrax, sulfasalazine, there's one more treatment called leflunomide or Lefno or Lefday or Lefra. So all of these treatments take 3 months to work. It doesn't work immediately. It takes at least 100 days to show effect. So you need to be patient with those treatments. They are not steroids. They're not painkillers. They alter the immune signals to your cells, which attack you, to tell that to calm down or not to be in attack mode. About 50 to 60% or maximum 70% of patients respond to this. The rest, 30 to 40% of patients, they don't respond. In these patients, we say that you can use anti-inflammatories as and when required. That is once in 3 days or weekly, twice or thrice. But if you're needing to take painkillers on a regular basis, where you're not able to stop painkillers, and even with painkillers, your pain level is more than 9 out of 10, that is 10 being very severe. 90% of the times, if you have very severe pain, not able to go to toilet also, not able to do activities of daily living, not able to function, not able to go for work, then at that time, we think of something called as biologicals or TNF blockers. TNF blockers are the ones which are revolutionary, which got invented in 1998, which basically suppresses a chemical called TNF alpha in your blood. And TNF alpha is the key cornerstone chemical or cytokine which causes inflammation, causing this axial disease or peripheral disease. So TNF blockers, if you see here in axial disease, there's no role for sulfasalazine. That is, if it's affecting only back or hip, if quality of life is much better with TNF alpha or biological agents. They come in the form of injections, in the IV injection form given through drips in our daycare unit in the clinic or in any hospital, called infliximab, coming with the brand name of Infimab. So it takes about 3 hours to finish one infusion. We normally give 200 mg, but if patient is above 80 kilos of age, and if not responding with 200 mg, we give 300 mg. So it's normally given 4 doses. First dose, 15 days later, second dose, and 1 month later, third dose. After that, 2 monthly or 3 monthly. I normally give 4 doses and tell patients that most patients do well with just 4 doses, provided you're physically very active, avoid red meat consumption, and you do daily exercises, you're not overweight. Then you normally, after 4 doses, you maintain well on SAS or sulfasalazine, at least for 2 years or 1 to 2 years of time. You're thereby, with giving this infliximab or infimab injection, your dependence on non-steroidal anti-inflammatory drugs or NSAIDs comes down hugely. Your dependence on your people at home for day-to-day activities comes down. Your fatigue or energy levels improves. Your quality of life improves. You're able to do not only your work, but even extracurricular activities. Your attacks of UV or inflammation comes down. Your inflammatory bowel disease, such as bowel problem, comes down. and your outlook in life changes. You become more positive minded and those things. So these days, the patient subsidies are there from the company, so which we often give that to the patients, and it's not very expensive at all. Um, so it's quite affordable in terms of treatment. I often tell this to patients that, if patients are bedbound or you lose your work, going to TNF blockers at early stages is much advantageous. Apart from infliximab, we also have injections given on the thigh by our clinic nurse. Later can be done by yourself, like insulin. So they come in the form of one 15 days called adalimumab, comes in various brand names. Most of it is available in the bio-intended copies or biosimilar versions in India, much cheaper than the original ones in outside India. It also comes in the form once in week called etanercept. So these self-taken injections, if not given in through drips, is given for milder disease. If it's severe disease, I often go for infliximab, because the only one which you give through IV can make you sit up within a week after the injection. Having said that, even adalimumab or etanercept works very well, but they are given for those patients which are not very, very severe disease. But 6 months therapy is what is required. Sometimes after stopping 6 months also, patients tend to need them. The disease comes back. At this stage, instead of giving 2 weekly ones, we give 3 weekly ones or monthly ones or 3 monthly ones. I have many patients who take 3 months once injection. Gradually we reduce it. And if you're giving infimab, if we need to give, we give top-up dose. That is like once in 3 months or once in 4 months. I have patients who take once in 8 months, and we tend to maintain them. Do not get down to the negativity of the disease. Patients often tell that, oh, this is a lifelong disease, doctor, I'm not able to stop treatment. I often tell them, at least you must be glad enough that treatments are working for you. There are many patients who treatment don't work and they get dependent on painkillers. So if you're able to live your life without painkillers, sparingly take either TNF blockers or sulfasalazine, then you must be happy that you're doing your day-to-day life without depending on anybody. Surgeries comes at the end stage here. That's why if you see surgery is put at the last and it's given a shorter size compared to others. That is only if your neck is fully fused and your neck is bent and you're not able to have a vision where you're not able to straight up and you're not able to move your neck for driving and other things. They do something called wedge osteotomy. That's at end stage and we don't generally recommend. Maybe out of 100 patients, or 100 is not the right comparison, maybe out of 1 lakh patients I might have referred one patient for surgery or something like that. It's that rare. So you see, this is a patient on biologicals. So before the treatment, the inflammation is there. Within 6 weeks, inflammation is reduced. And at 6 months, inflammation is fully gone. Same thing, this is again with biological spine inflammation is there. At week 12, you see, it's completely gone. So any of these treatments, such as infliximab, adalimumab, or etanercept, have a magical relief in these patients. These days, there's one more new chemical called comes Scafo, secukinumab. Some of my patients are on it. Advantage of Scafo, it works very well for psoriasis, and TB risks in Scafo is very less. Tuberculosis is something which can happen in these biological patients. So we often screen patients before that, and some of my patients are put on TB protecting treatments, things like arsenex and benadone or Solonex, even for about 3 to 4 months or sometimes during the duration of therapy. They're very less TB risks, they're not very high, but TB happens also, then we are able to treat you, not an issue at all. But Scafo, generally TB risk is less. But this problem with Scafo is it has to be used with 300 mg dose and the cost shoots up, and works not very high for joints, brilliant for skin in case of psoriasis. So this is something which last 5 years it's been there in India, so working very well. I have to talk to you about psoriatic arthritis because it affects spine. So, psoriasis causes flaky dandruff, uveitis. It can cause bowel disease. It can cause a lot of anxiety and depression because of extreme skin involvement, and it can cause neck and back pain. That is where I'm talking to you about this, and can causes joint pains as well. So, it's a genetic disease affecting skin. Uh, and affects various parts of the body also, causing back of the heel or Achilles tendon pain, dactylitis, where toes gets affected. um, and it affects when the body's immune system attacked our healthy tissue, and it can cause spine problems, skin problem, joint problem, and can cause nail problem and heel problem, Achilles tendon problem. So several parts of the body. Okay. So that's where involving a rheumatologist earlier on, because we are able to identify all this and give you treatment. So if you have painful stiff joints, back pain, neck pain, crumpled, pitted nails, skin rashes, eye inflammation, any of these can happen, extreme tiredness, or one at a time can happen. And it can affect the finger problem, spine problem, deforming arthritis, and back of the heel problem or whole swollen toe. So if you have psoriasis, you have a 50% risk. If you have either anybody in the family, that is first degree relatives or secondary relatives, first degree are this, second degree are this, that can cause gene penetration in you also. Generally, 40 to 50 years are more prone. Obese people are more prone. Smokers are more prone. Extreme degree of stress, either physical or emotional, are more prone. So if you have skin psoriasis or nail involvement or joints, and anybody in the family having it, then that's all you need for diagnosis of psoriatic arthritis. We do blood tests, but that's mainly to check whether you have high inflammation, that is ESRCRP, or liver problems such as fatty liver. And imaging is to see whether you have affecting of your spine. So early disease diagnosis, when even 6 months delay makes you dependent on people, loss of work, loss of education, and things like that. Doctor will ask about your family history, personal history, and all that. Examination is to see how well you can move, basically. And X-ray, such as X-rays or MRIs, are to see bone damage and involvement of your hip joint and spine joint. Lab test is, we do something called HLA-B27. In psoriasis, about 25 to 30% of patients have positivity, but that shows that it's a lifelong disease if you're gene positive, but treatment won't be lifelong, maximum for a period of 2 years of time. So treatment is the same, what I told as disease-modifying anti-rheumatic drug therapy, sulfasalazine, methotrexate, leflunomide. These days, I didn't speak about JAK inhibitors, that is tofacitinib, which is available in generic forms. Called many brands are there. Tofashine is one of them. Tofacitinib is something which causes, which blocks a particular chemical called JAK kinases, which are signal blockers, and production of the cytokines are blocked. It's given in the 5 mg morning and night form. So that reduces your dependence on painkillers, reduces dependence on your biological agents, such as all those injections, which I told you. So these days we've been using them well, and even post giving 6 months of biologics, we use them so that you don't depend on going back on them. So treatment is in form of painkillers or these disease-modifying drug therapy, which I told you. They control severity of inflammation, degree of joint damage, and it works for the other parts of the body also. So treatment is mainly to improve your symptoms, able for you to perform very well, function very well, and improve your quality of life. So non-pharmacological includes exercises, occupational therapy, or adjusting your work pattern or your living pattern at house, and pharmacological treatment such as painkillers, anti-rheumatic drug therapy, which I just told you, SAS or Lefno or methotrexate, Left-Day or Folitrax or Mexate, or biological agents, which I just told you, or even JAK inhibitors such as tofacitinib. Surgery is done at a later stage, very, very later stage. These days, I hardly refer patients to surgery. They don't need surgery if treated very well. So, exercises to improve your strength, your endurance, your physical capacity is very important. Giving hot and cold therapies. So, hot therapies are usually preferred where you use a towel. I often say use a turkey kind of a towel and soak it in warm water, squeeze, and wrap it as shown in this. And poster training and adaptive treatment, such as using form of frames to support yourself for walking, at least when you're initially dependent, is important. Medications to improve inflammation, that is what you call as painkillers. We use anti-inflammatories once in 3 days, can be taken. If you have function at home, travel, you can use it more. Steroids have very little role in this disease, but can be given for joint injections when we normally do in our clinic, or can be used as a buttock injection or muscular injection when we see that overall body is inflamed. But they are used as a stopgap therapy only. And stopping treatment with suddenly steroids, if you're on, can have problems. So gradual tapering is what is required. But steroid treatment these days in rheumatology, we are very, very less using. And if used by rheumatologists, we use it very caution. And none of these tablets have major side effects, either methotrexate or sulfasalazine or leflunomide or tofacitinib or biological actions. So they alter your immune cells and control the negativity of the immune cells, and can be used, up to 2 years or even beyond. Some patients take it for lifelong if they need it. Normally we use for 2 years and then try and stop and see. If your body is able to do without medicines, we stop and see. Provided you're physically fit, avoid red meat consumption. I'll come to diet shortly. Then you're able to stop the treatment. Problem mistake patients make is once they get better, they stop exercises. That's what you should not do. And biological patients, when we use infliximab or adalimumab or etanercept or secukinumab or scafo, they are used from biotechnology and they're used for severe disease. And if in spite of using any of these agents, when your painkiller is not able to stop, then we use this. So we do TB screening before we put you on that. And sometimes we give you TB protection treatment along with this so that you don't develop tuberculosis when you use them. Rarely we use beyond 6 months. Even if you use beyond 6 months, we use in reduced durations of frequencies. And normally you do very well by using those. So in pregnancy, in ankylosing spondylitis or psoriasis, we use treatment. They are very, very safe. Sulfasalazine is extremely safe. We use that in pregnancy. We use with folic acid that won't harm your baby. Painkillers we don't use, so we use paracetamol during pregnancy. Joint injections can be done during pregnancy, including sacroiliic joint injections, can be done on ultrasound guidance. Biologicals such as anti-TNF can be used in pregnancy up till 6 months of pregnancy. Last 3 months we don't use, and we use even in breastfeeding. And tofacitinib we don't use in pregnancy. We stop during pregnancy. Breastfeeding also we don't use. Physical therapy is cornerstone, that the exercises. So range of movements is greatly improved with exercises. Posture control is better. Muscle strength is better. Your balance is better, and your cardiovascular fitness is much better. Even for fatty liver disease, where raised SGPT is seen in this psoriasis or ankylosing spondylitis, is much better. All those which is shown in red cross, don't eat. Now, milk, low-fat milk is okay. Oil, olive oil or low-fat oil is better. Cheese, butter, ghee, sugar, chips, packeted items, cornflakes in terms of, highly processed, don't take. Oats is fine. Salt, heavy salt, cola drinks, bottled fruit juices, Pepsi, burger, lemonade, Fanta, Coke, pizza. No, 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 no. Okay. Once your disease is controlled, once a month is fine. All in green is allowed. All fresh fruits, veggies, multigrain bread, fresh fruits, fresh fruit juices, plenty of water. Okay. And in terms of red meat, don't take. Other chicken, fish, and egg is fine, right? Alcohol, maybe once a week, that too in limited quantities. Cigarette smoking, definitely no. Fish is okay. Chicken, boiled better, fried once a week, okay. And a balanced diet is very important. You have to avoid your risk of heart disease, diabetes. These days, 1 in 3 Indians is diabetic, or 1 in 2, you can say. So diet is very key. Yeah. So you must follow this. Watch your weight. Very, very important. Losing weight can reduce your disease severity. Fat cells secrete some of the substances involved, cytokines in psoriatic arthritis, or even in ankylosing spondylitis, or even in your mechanical back pain. So weight reduction is something you must follow. Very, very important. Pain control. Not everybody in ankylosing spondylitis have the same intensity and duration of pain. Some might have mechanical pain or muscle pains, which I showed you the first slide. So talking to your rheumatologist to say what is inflammatory pain, what is neck pain, what is muscle pain, will be able to help. It is not predictable as to who will have what kind of pain. So only a doctor or physio will be able to find out. But pain is something, never get bogged down, never get emotional or depressed. Have faith in yourself, have faith in your treatment, and talk to your doctor. If your pain is not controlled, we'll be able to figure out some muscle relaxants, which will give you, can take it at night, it'll give you good sleep also. And talk to your physio. Yeah. So personal consultation or video consultation, if you're not able to meet in person during COVID pandemic, will help you. So managing pain, apart from your painkillers or muscle relaxant, physios can use something called as TANS, electric nerve stimulation machines, or TENS, or ice and cold pack or heat pack. And that will give you some kind of symptomatic relief with your pain relief. So what you can do, taking medications as prescribed by your doctor, a rheumatologist, keeping a good posture, avoid prolonged sitting, every 20-minute break, pacing your activities. Don't be over optimistic. Don't say that everything I have to do on this Sunday only. Break. I often tell half an hour work, 10-minute break, half an hour work, 10-minute break. What you aim to achieve in 4 hours, break it into parts. See, all of us are humans. And these days with COVID pandemic, we are all in stress. Kids are stressed because they have to do everything online, projects, everything. Mom is stressed because apart from doing household activities, looking after husband or parents or in-laws, they have to look after kids' online education. All males are stressed because not only working from home, your job problems and all those things. So we are all dealing with that. So be optimistic of what you can achieve. Very, very important. Exercise regularly. 30 minutes of physical activity, friends, will make us into good human beings. It will give us a lot of positive energy. It will give endorphins to face our stress, and will give us positive outlook in life and minimizing stress levels. We can achieve only what we can achieve. That's why faith or trust in God, in whatever religion you belong to, or trust in a superpower, even if you don't believe in God, something which is controlling all of us. Take the example of Corona. It was not anybody's thing. Some accidental leak happened somewhere. All of us are facing the brunt for that. So some superpower which is controlling all of us. Have faith in that. You may not want to call it God, but have faith in that power. Some may want to call it science, and say that one day something good will happen to me. We all live in hope. Hope is very important, friends. Without that, none of us can get better, right? Pacing is something which I told you, slow down. Sometimes slowing down can make you work faster. So slowing down is what pacing means. So trying to do all in one go make you feel more tired. So pacing is, you tell short goals you achieve, will have focus energy to achieve things. Okay. And basic principle, look at your jobs activities which are only essential you do if you are very tired, and can be done on another day. There's no harm in that. And try and delegate things which you can use your help to see who can do things for you, and do activities within 30 to 40 minutes span and give 10 minutes break. So that is very, very important in terms of achieving or knowing your limitations. Yeah. And exercises can be of the neck, can be of shoulders, can be of the lower back. Uh, so all of these, your physios will go through, and YouTube videos are there as well. Benefits of exercise: improves your flexibility, increasing your range of motion, improves your sleep quality, and reduces your pain and stiffness. So improves your movements, your posture control, muscle strength, length or stretching, lung capacity, balance, cardiovascular. All of these are improved with your exercises. You can either join a group, where we used to do group yoga in our center, but because of COVID, we have stopped it. Shortly, we'll be starting an online program also for group yoga, and individual exercise program as well you can do. So slowly build the exercise, don't do in one go, but daily do at least 20 minutes of it, where all of these are important: stretching, mobility, breathing, cardiovascular. Swimming, these days with COVID, most of the centers are blocked, but once summer starts, hopefully, now that COVID has become almost endemic in most countries, and all of us have had 2 jabs, hopefully, COVID jabs. So once the summer starts, swimming is a good overall exercise, if you can learn it. So your physiotherapist might also recommend some of the fit ball exercises to improve your roll or muscle strength. So some of the things which you can do: yoga, Pilates, Tai Chi, spinning, water aerobics, Zumba, Nordic walking. So all of these you can talk to your fitness trainer, your yoga therapist, to go through this in detail. Maintain an exercise diary that will kind of give you stimulation of how much you have done every day, and that's very, very important. And you actually, this is important thing, you actually note down and discuss with your doctor as to 10 you are extremely enjoyable doing exercises, 10 not enjoyable at all, and discuss how much you are, and your doctor can support with adequate sort of pain medicines or anti-inflammatories, or even disease modifying therapy, to say that you're not at all enjoying exercise but you're still doing that. Everything in life should be enjoyable, friends, so that you can cover. If you're still having a flare up, you still need to exercise, but cut down on the amount of exercise. Ensure you have adequate rest between exercises, and do consider water exercises. Okay. So maintain good posture, either standing, walking. These are bad postures. We should not, because bad postures create muscle spasms. Yeah. Posture control is quite important. So ability to raise your arm, to sit down properly, and if you're using computer, ensure that your positioning is correct. These days, most occupational therapists have YouTube videos to tell us how to sit for a computer table to work. Surgery is really at the end stage, and most patients with ankylosing spondylitis will not. However, if I told you that your hip joints are fully worn out, they are not able to stand, then you need hip replacements. If done properly, they do wonders. These days, most hip replacement surgeries are success for 20, 30 years. And spine surgeries are very rare. So hip surgeries are frequent if your disease is very, very advanced. And even after biological treatments, you're not able to stand or do work, then hip surgeries are needed. I thank you a lot, and thank you for spending your Sunday for this. And so, Divisha Arthritis and Medical Center, we are in Basveshwanagar, Bengaluru. This is a number per appointment, and we have our own website, which are lots of patient education videos. And I wish you all very good life, and may God give you all strength in this COVID pandemic, and also with the back pain you have. Thank you very much, and God bless you all. Any questions are there? Any questions from any of the patients?
Yeah, there were questions, Doctor. Dinesh, can you just share those questions to sir?
So please start questions from one by one. You can start reading out. I can address it here only.
Sure.
Or you can share it to me. So I have a question from Yamuna.
Yeah.
Taking methotrexate once in a week, 15 mg life, is it life threatening? No, not at all. Not at all, Yamuna. Don't be under that. Never take things negativity, Yamuna madam. Methotrexate 15 mg is safe tablet. Lifelong is not required. There are treatments which can reduce your methotrexate dependence. Please contact us, not an issue. With slowly, with treatment, you will be able to do very well. Not an issue at all. Shweta Chaperia, I have low back pain whenever it is high workload. Very common, Shweta ji. I told you, you need to strengthen your back muscles, reduce the quantity of work you do. Do 30 minutes work, 10 minutes break, 30 minutes work, 10-minute break. Contact a physio for what we call as core strengthening exercises, where your abdomen and back is all strengthened. That is very, very, very important. So, 4 times a year, and make sure you do some blood work and x-ray and contact rheumatologist so that inflammation is ruled out. Acharuddin, what is the cause of ankylosing spondylitis? Acharuddin, sir, ये ankylosing spondylitis genetic बीमारी है. So जीन डिफेक्ट से होता है. सो जीन खराब होने से होता है. यह इम्यून सिस्टम खराब होने से आपको शरीर को ही अटैक करता है. सही ट्रीटमेंट लेने से आप अच्छे हो जाएंगे, कोई तकलीफ नहीं रहेगा. बट एक्सरसाइजेस रेगुलरली करना है, स्मोकिंग नहीं करना है. प्रेरित, what are the preventive measures to control ankylosing spondylitis? Most important, take treatments regularly, avoid prolonged sitting, avoid red meat consumption, avoid smoking, alcohol in moderation, and do regular physical activity. That's what I think we should do. Anything else is there? Questions? Vijay Kumar. So I have osteoporosis and I am on parathyroid hormone therapy. Need to be consulted with rheumatologist or continue with orthopedic doctor. Vijay Kumar, you have to consult rheumatologist, because rheumatologist will know the cause of osteoporosis, the best preventive treatment of osteoporosis, exercise regime as osteoporosis. So rheumatologist is much better for osteoporosis. I think so. You have to do. Sheila Anand, my hand shivers sometimes, both hands, only my palm. Hand shivering is very common. Sometimes we call essential tremors. It runs in families. So for that, make sure important things you need to rule out is contact a rheumatologist to actually check whether there are any side effects of the medicines which you're taking. Some of the asthma medicines can make you hand shiver. Extreme nervousness or anxiety can make it. Lack of muscle strength can make it. So contact a physiotherapist. And sometimes, it's something called essential tremors, which runs in families. At this stage, a neurologist will be able to find out whether they give some medicines called beta blockers. It will be helpful. Is seronegative inflammatory arthritis and ankylosing spondylitis one and the same, Arjun? Yes, Arjun, they are one and the same. It's like causing, telling Sunday as Ravivar or Banwara. It's one and the same, different names. Seronegative inflammatory arthritis is a broad term. So ankylosing spondylitis was the old term where they cause only for spine problem. Now seronegative spondyloarthritis is a better term because it, as I told you, it affects eyes, it affects spine, it affects hands, feet, lower back, it affects intestines, skin, nails. It's a better term that way. Any other questions? I really thank Digital Infomedia and Sun Pharma for giving this platform to educate my patients. I often love patient education, but the only issue is I practice from morning 8 a.m. till evening 9 a.m. in my clinic. So only time I get is Sunday. So that's what I told these companies who do patient education. So I'm grateful to them to have given me this platform to help patients. Any other questions are there?
No, sir.
Okay. Shall we end the program then?
Yes, sir. And thanks a lot for a wonderful learning session. I'm sure many patients will feel much better on hearing your positive momentum on the disease to have a better control of life and disease. Thanks a lot for the valuable time and energy, sir.
Thank you very much. I'm very grateful for all of you for spending Sunday for this.
Thank you, sir. So kind of you.